Thanks a lot. We have about 10 minutes to take your questions up here. As this person's coming up, I'm going to ask Rohan one thing here. So as your role as the program director, leader, you're in close contact with all of the kids coming out now, right? I mean, every year you run the symposium at our conference specifically for the fellows. Please tell us their angst. There are people coming out now with incredible resumes, all right? They have the AHPBA training, they have the MIS training, and they're coming out wanting to do complex upper HPB surgery. Tell me what it's like for them in the job market and what you've heard back from them about how it's going.
Yeah, and I think I would like to say, Chuck, that it's true of many of our fellows that are coming out, even in other arenas. It seems that it's just tough. It's really tough to find the right job. And I think the truly academic jobs are hard to come by now. And so our model, I mean, just for full disclosure, I'm in private practice now. And so my passion is to present that way of thinking also. So I always say that, you know, whatever you're going to do, you probably have to be happy doing something else. So if you trained in transplant, you have to be happy doing kidneys while you're building the HPB volume. If you're trained in HPB, you probably have to do general surgery while the HPB volume grows. It takes a while. And I think you have to be patient, and there's never the perfect job. You have to make it perfect and look for the opportunities that are present.
Yes, sir.
Peter Cosman from Sydney. As a pancreatic surgeon, I never stop learning, and that's why I think you start off doing easier cases, but then you start getting a bit braver and taking on more and more advanced things, and then you end up with IRE, which I tried to get going at our institution last year as an investigational procedure, and I cited the paper by Martin in support of trying to get that up and going. We had multidisciplinary discussions around which patients might be suitable, how we would approach it and so on. And we finally lined up our first patient, and the whole executive and bureaucratic mass just fell on top of me, like I was trying to sell them snake oil. I found that really difficult to contend with, particularly when, in 2009, I think, whenever it was, when the Moore paper came out in JCO, showing that GEM plus Tarceva was better than GEM alone. The oncologists were celebrating all over the country, even though the survival benefit was less than 2 weeks. How did you get over that kind of bias, and how did you sort of get the right people to back what you're trying to do?
Sure. So, I think obviously what you're saying is true anywhere. It's not just Australia. We all have those same challenges. At our center, because it is really a very developed pancreatic center, Chuck was just saying briefly, every Thursday we're all in the same room together, all the oncologists, all the radiologists, the surgeons, the nutritionists, everybody that's involved in a patient with pancreatic cancer is involved. And we have seen the whole spectrum of patients with pancreatic cancer, and it took one case to kind of start greasing the wheels a little bit of the oncologists, but they're in the same they're in the same game that we are. And I think the way that we run the center is really that it's not the tunnel vision of one discipline that runs what's going to be done, and it's also not the ego of the surgeon that determines what's going to be done. And we really just got to a point where we look at what's the best for the patient, and we felt that in some patients IRE was going to be the best thing. We did do full neoadjuvant therapy. There are a lot of groups that don't do full neoadjuvant therapy before IRE, so because of that we got the buy-in of the oncologists, because they weren't losing their patients and they were doing what they thought was in the best interest of the patient. The patients do get their adjuvant therapy after. The patients are still getting their radiotherapy. So it's not like we're using this as one tool within the entire toolbox that we have. And I think by setting up what our goals are for the patient early on, and then, you know, saying, okay, we're going to go forward with IRE, we're not going to, not just being stubborn about what we want to do, we've been able to get ahead. But we've had a big learning experience at the center, and we have one oncologist who just, every patient, we joke because he calls it the IRE, and why don't we use the IRE on the patient? He's like, all my patients do great with the IRE, and we're just like, this patient has a 20-centimeter tumor, we're not using the IRE. But you know, I just think it takes a lot of time, but really collaboration is king.
I think you meant the IRB.
I was just going to add that I would really encourage you to do margin accentuation. I think there's very little downside to that, and I think it allows you to really look at the tool.
That's what we're trying to do with the officers who came from the administration and other clinicians.
That's interesting.
So the interesting thing is that you showed the data about your bad outcomes and they being clustered in the locally advanced group that you were trying to, you know, debulk, so to speak.
Right.
Yet it clashed with your first slide about, hey, this is good because it's not going to affect your local structures.
Right.
This sounds a lot like radiofrequency ablation to the pancreas, which has been pushed in Verona, Italy. Same idea, just a different tool to do that, where the exact same problems are coming out, duodenal issues and venous things. Could you tell us a little bit about that?
So in theory, you're not supposed to damage vital structures. There's not supposed to be a thermal effect, but there is a large body of literature emerging that there is truly a thermal effect, and that it's very hard to regulate because these tumors are so heterogeneous, and because, as we all know, these tumors are so desmoplastic, and to generate current through those tissues, there's going to be some networks where the current shoots right through, and there's going to be other networks where you can't get the current through, so it's going to find its way around there. And because the majority of the current's not going straight from probe to probe, but finding little networks where it's going to go through, there's definitely going to be thermal buildup in those areas. A lot of groups feel that there's absolutely no chance that there's thermal, and they've done ex vivo studies and, you know, dead liver that's, you know, freezed right out of the refrigerator and using all sorts of advanced probes to kind of do, and they say there's no thermal effect. But in the body, it's not like a piece of liver sitting on a bench, and I think there really is definitely a thermal effect, and that is destructive. Most of our complications, I know it looks like we're running over and we have one more question, most of our complications, I would say, are really thermal effects on the duodenum and thermal effects on the bile duct. And what we're doing now is actually we're putting a stitch in the duodenum when we resect something so that the pathologist can look at the duodenum to see if there's really thermal burn in those areas.
Good. We have an option for 2 minutes, one question, please. Thank you.
So I got a question for Dr. Karen. You mentioned that in your, the best way to treat, to get a clear drain in a wall of pancreatic necrosis is to upsize the catheters to 18 French. So typically our interventional radiologists put in a 10-12 French at the first setting. So how frequently then should we keep on changing the catheters and upsizing them?
You know, I think I don't think that there's any one right answer for that. Sometimes a 10 to 12 French drain is actually effective. I think that what we do is we usually use a CAT scan in a very short period of time after. So we put in the drain and wait for a week or so, and then re-CT the patient. And if we're not making, you know, if you go from a 12 centimeter size collection to a 10 centimeter size collection, you are making progress, but that's not fast enough. In these patients, I think once you decide to intervene, you need to be making some faster progress than that. So we do use CT. Sometimes we'll upsize to an 18. Sometimes we'll then upsize even to a 20, a 22. I think that one of the things that we've definitely found is that by increasing the volume of the flushes, we really have saved the upsizing. We don't have to be as aggressive. I think it's a huge key to success.
Thanks. We're going to wrap it up.